Thank you very much for the introduction. It's always good to switch gears, and I grant that to Dr. Samah. She cleverly, strategically places the lectures, so it will be very interesting. I was also amazed about the lecture or the speaker, Dr. Ramesh, and how ablation is very sophisticated method of treating AF. I mean, speaking about the catheter and the risk taken by the operator themselves, it must be really stressful for them, as well as, you know, the safety of the patient. He spoke about, you know, possible risks. Yeah. Hello. Yeah, it's great. Yeah, I like to walk around, see my audience is better. So, yeah, thank you. So, I'm sure that we don't want everything that's been happening to go to waste, isn't it? It's counterintuitive, actually, to do all these procedures and then it's doomed to fail. I hope you don't take it arrogant of me that I will tell you, without losing weight, everything we spoke about today is unfortunately doomed to fail, okay? At least at a higher percentage, all right? That will be very stressful to the operator themselves, as well as the patient. So let me start simply. So this is my objective of the day, and simply we'll start about the epidemiology of obesity. So obesity is nothing but the accumulation of fat in the body, or a state of higher adiposity, all right? The way to measure obesity is actually by simply calculating what's called the BMI, the body mass index. And we can do that simply by dividing the weight over the height in meter, then taking the square of that. So I will tell you that obesity now is recognized as a disease. So when you write, I know you're really good. All cardiologists are always mentioning obesity, and they are concerned with obesity. I know that is part of the risk factor, but obesity is a disease now. So when you mark it down, it is the same as marking hypertension, diabetes. You cannot just mark it and not treat it. I hope this gets to everybody. So, sorry, go forward. So how does the world look? It's unfortunately not so good. So this is a map of the world, and you can appreciate that even in places that we know they suffer from hunger and famine, they still have obesity, like Sub-Sahara desert of Africa and Somalia. They still have obesity. A shocking survey or a statistic came out in 2012, and they said, nowadays we have more overfed mouth than hungry mouth, unfortunately. So how does it look at our area? Unfortunately, we are the highest of the incidence of obesity, Kuwait being today the highest or the top one country of obesity, unfortunately. And this is what I'm speaking about. When we take the cohort of obesity, this is the number of people, let's say 100% of obese people, the one that they get diagnosed. And I can tell you diagnosis of obesity is really straightforward. The patient will come actually diagnosing themselves with obesity. So it's the easiest job in the world, should you want to switch jobs. Only 20% or less, they will receive the treatment specifically for obesity. And unfortunately, 1.3 will continue to be in the anti-obesity medication. So we know now about obesity. So let's say the connection between obesity and AF. This is a good study. I think this is the Danish study. Yeah, this is the Danish diet study by L. Frost and others. And they have found following up patient or the cohort for certain of years, the more adiposity or being obese will actually make you vulnerable or more at higher risk of developing AF. This is another study. This is the women's study, and they have shown that every 1 unit of BMI will increase your incidence or the happening of AF by 4.7, let's say 5%. So if you think about the lowest grade of obesity, which is the 30 BMI, to the highest grade of obesity, that's like, the beginning of the grade 3 obesity, which is the 40 BMI, that's 10 units, will actually make you almost 50% susceptible to AF. This is another study that shows that the longer they actually followed up people and say the surveillance or the AF-free percentage of them, the percentage of people that will have AF-free life along their course of life, and they have shown that the same thing. The more you are obese, the more likely you will have AF. And the most warranting to check here is if you lose weight, say if you are not obese and you go to normal, you will have a significant increase of having a life without AF. This is also, again, the hazard ratio of having AF divided by the BMI or the weight. And as you can see that the more weight you have, the more vulnerable you are to AF. So why does that happen? And Dr. Ramesh, I have to thank him for that. He really explained everything about what's happening in the pericardial fat and the process of that, and I will touch on it very quickly. So we use always to think about fat being nice, being benign, being cute, and being funny, right? It is not that, unfortunately. So there is the fat tissue or adipose tissue is actually an active tissue, and it's not acting very well, okay? So part of that, they contribute to a lot of pathways that is known to be harmful to the body. One of which is the free fatty acid, which activate the oxidative stress, and you all know that the oxidative stress work on different parts of the body, and specifically in cardiology, it's in endothelial tissue. And again, the fat tissue is harboring cells for the inflammatory tissue, all right? So it works on releasing different inflammatory tissue signals like IL-6, TNF-alpha, and others, and those specifically will cause, again, the same stress as well as increasing your resistance to insulin and being hyperglycemic. Also, the renin-angiotensin system, which you are all considered or really have a high consideration about, and as you all know, that will also cause hypertension. The fat tissue is known to release leptin. Leptin is, you can say, it's a signal of satiety, all right? And the more fat you have, actually, you will have more leptin, but it will not be effective. It will not work as a satiety signal. It will actually block the satiety and make those people eat more. Now, we know leptin also work on the epinephrine or the, I forgot the name. So it works on the epinephrine, non-epinephrine system, and that will cause more hypoxia to different side of the tissues. As Dr. Ramesh explained, the pericardium, which is made up of fat, and this fat, as I described earlier, will cause the inflammation, whether it's local and systemic as well. And all of these processes are happening inside the pericardium and of course, and endocardium, and of course that contributes to the AF and the fibrosis that's happening and the decreased electrical pathway, or making the electrical pathway more resistant. So this is the systemic effect of obesity. and this is also the local effect of obesity. And as I was saying earlier, that they contribute to different pathway, and that unfortunately will cause AF and make AF being resistant. Again, this is the same pathway, and it shows you that it is a vicious cycle. So being obese actually is like being trapped in this disease. And the more you become obese, the more the problem will increase, and the more you will face a resistance to control this issue or this disease. And it will make you more sick. Being more sick will accumulate fat more due to being unable to exercise, unable to adhere to your diet, etc. So let's say the impact of weight loss. What does it do for AF and the treatment of AF? So these are actually, this is a summary of the best 5 studies that have been looking for or looking over obesity and AF. The first one is actually an observational study. And in this observational study, they have followed people and have seen the effect of weight loss over the AF and its sequelae. They have found that decreasing your body mass index, or losing weight, will decrease the AF burden, the frequency, and all AF related complications. The rest of the slides or the studies are actually RCTs, and we know they are the best evidence available. So the arrest AF, actually, this is, I think, will be more concerned with the ablation. So what they have done, they have made people to lose weight before going to ablation, and they have looked at the 2 different arms of the study, whether the weight loss will affect the successfulness of the ablation. And what they have found, actually, that if you can see the upper module, which is the single procedure, so the effectiveness of a single procedure actually was 32%, and the multiple procedure, which is multiple ablation, went up to 87% when compared to the control, who did not lose weight, which were 18%. So there is a significantly high effect of losing weight before going to ablation. It's almost 70% higher success rate. And then the legacy, which is another RCT, they have actually measured the amount needed for weight loss before going also to the AF ablation. And they found that more than 10% of weight loss will cause a significantly high AF freedom at a rate of 86%. The CardioFit, the same thing, they measured weight loss as well as exercise. And what was the effect of that? So a 10%, more than 10% weight loss plus a high exercise rate will cause an AF-free life almost 94% of the time. This is a very interesting study. This is called reverse AF. So what they have done is they had 2 arms. One is the control, and the other one is the weight loss arm. And those who lost more than 10%, they actually had a reversal of the progression of AF. And that shows you that even without intervening, you could really say improve AF. I wouldn't say really cure AF, but you actually can improve AF by weight loss alone. This is another study. This is specifically for one molecule, I believe, which is the liraglutide pre-ablation. Or no, sorry, this is actually by P and Olds. They had a weight loss prior to the ablation, and you can see that the weight loss actually improves the the AF-free life after the ablation, and when compared to the weight gain, which actually worsened the situation. So not only they have to lose weight before the ablation, they have to continue keeping that weight off even after the ablation. Otherwise, AF can return. And that's why I was so preservative when it comes to saying cure of AF, because AF can come back, unfortunately. Now, what do we do in my specialty? According to the BMI that we have, we can give a treatment modality. So if for the overweight and low obesity classes, we can use the exercise, of course, and the lifestyle modification, but we can also use the medication. And you can escalate this treatment up to surgical intervention. These are some examples of the FDA-approved weight loss surgical procedures, and they still keep the high rate of weight loss up till today. Surgery is feasible after AF, so don't let an AF patient deter you from going to bariatric surgery or sending your patient to bariatric surgery. The non-surgical pathway can be starting with the balloons, which is devices that we can put inside the stomach, will decrease the weight loss as well. And these are the treatment that has been for a long time now. Some of them are FDA approved, some of them are EMA and FDA approved. And these are all tablets, and they work in different pathways. Unfortunately, lorcaserin has been retracted from the market. The new medications nowadays are all being injectables, and they are all under a certain class, which is the GLP-1. And they have different efficacy and weight loss rate. We started with Saxenda or liraglutide, which has been for a long time in the market, around since 2014, I believe, and the weight loss was around 10%. Then we had a long-acting medication, which is the semaglutide, and it had a really great weight loss as well, almost reaching 16% on average. And then tirzepatide came out, made a huge impact. They now call it the substitute of surgery, reaching almost 22% of weight loss. And they all, of course, they have their own dosage, and you have to take it gradually. It's honestly very easy. All of you here can, follow this protocol, and you can by yourself actually use this in your patient, and you can reach a great result with them. This is again for a specific, this is a study for a specific agent, which is liraglutide, and they have shown that using liraglutide actually increases the AF or the AF-free complication of the AF complication, sorry. So the take-home message: obesity is closely related to the presence of AF. The success rate of treatment of AF, especially the ablation, is very closely related to having obesity or not, and the level of or the class of obesity and the weight status. Small weight loss needed, 10%, to even reverse the effect of AF or reverse the progression of AF. Treatment of obesity, whether medical or surgical, is really